All right, welcome everybody. We are here with Dr. Erik Blomain, who is a radiation oncologist from Thomas Jefferson in Philadelphia, Pennsylvania. We also have with us Dr. Naifa Busaidy, who's from MD Anderson. She's an endocrinologist and associate professor at the Department of Endocrine Neoplasia and Hormonal Disorders. And also we have Dr. Sarah Oltmann, who's an endocrine surgeon and associate program chief of quality and best practice, medical director of the general surgery clinics, and director of endocrine surgery for Parkland Health Hospital Systems in Dallas, Texas. Welcome all of you doctors. Thank you so much for your time.
Thank you so much. So this is a nice small group. So if you guys want, if you're comfortable where you are, that's fine. If you want to move closer, that's fine. We're going to try and make this interactive. We just have a few slides that will go over some definitions and some ideas. And what I'd like to, so this session, to make sure you're in the right session, is being your own patient advocate. Do you have the right medical team? When is it time for a second opinion? And when do I need an oncologist? And so those are the topics that we're going to cover. And I think that our panel is actually very interesting. So I'd like us to start with some introductions because I think the two people that I'm with are very interesting. So I'm going to start on my left, or I don't know on Zoom what side you're on, but with Dr. Erik Blomain, if he can just tell him a little bit about himself, and then we'll go from there.
Yeah, hi. Nice to be here with all of you. I'm, as Kathleen said, I'm a radiation oncologist at Thomas Jefferson University in Philadelphia, and I treat a variety of cancers there and as my clinical duties, but separately and kind of pursuant to this talk, I'm also a 15-year thyroid cancer survivor and patient advocate on the NCCN Thyroid Guidelines Committee. So I've been the last couple of years very involved in the advocacy space too. So I'm hoping to bring kind of both expertise to the panel.
For those that don't know, sorry to interrupt, the NCCN, or National Comprehensive Cancer Network, are one of the biggest bodies that make guidelines for cancer. And so Erik's been sitting on that panel, and it's great. And next, next we have Dr. Sarah Oltmann, as you heard, and I want her to introduce herself.
Hi, I'm an endocrine surgeon. I practice in Dallas, Texas. I was diagnosed with thyroid cancer during my surgical training, and it really became a pivotal point to direct my path into endocrine surgery specifically. I found when I had my diagnosis, even though I was halfway through training, I knew what the textbook said. But what I found most helpful was my surgeon put me in touch with a patient that I had taken care of with her when I was on her service, and speaking to another patient and hearing about their experience, about what it feels like, what am I going to experience in that post-op period, what am I going to experience with all of these different things, I found was the most helpful and a way to kind of reconcile what I knew with my doctor brain versus what I was feeling in my heart with all the words that were being spoken to me. And so it has been a very rewarding place for me to have my career, and I'm very happy to be here today.
Yeah, so I think you'll hear some unique perspectives that you maybe don't necessarily hear. I'm boring. I'm an endocrinologist. I love what I do, and I treat patients with thyroid cancer and do clinical trials. Not a thyroid cancer patient, so I don't have a cool story, but I hope to bring different perspectives. So with that, we're going to go through what the medical team looks like, and then where we go from here. And Dr. Blomain and Oltmann may interrupt any time. And if you guys have questions that are burning that you don't want to wait till the end, you can ask at any time as well, because it's a nice small group. So when the patients first starts their journey, their medical team can include a technician or a doc that does the screening ultrasound. So from a healthcare technician that found this nodule that sent you to the doctor in the first place. It may start with a primary care doctor, right? You felt something, or they felt something and they ordered it. And then the endocrinologist is typically the medical doctor, right? Who takes care of you probably from beginning to end in the treatment. And the surgeon, who's going to do awesome things and cure you. And then the radiation oncologist, who treats you either with radioactive iodine or radiation. And then the oncologist. And the medical oncologist, thankfully, has, for the vast majority of thyroid cancer patients, a smaller role, and only for the most advanced cases typically. Although if you're in a smaller town, an oncologist may be doing what the endocrinologist did in other places.
And depending on where you are, the order that you meet these people can be quite different. And a lot of the places, your focus team is really however your thyroid nodule is picked up. I've had patients come to me after a car accident. As a surgeon, I actually am the first person a lot of them meet. They don't necessarily come from an endocrinologist. They come from primary care or the emergency room or their internal medicine doctor. And so we start with the biopsies. And as I'm sure many of you, the diagnosis of cancer may not have been known at the beginning of this journey, that it's something that came sort of after the fact. I guess some other people that are missing are nuclear medicine is another type of radiologist who in a lot of centers are sort of the keepers of the radioactive iodine, so to speak. And we work as a team. But a lot of what this list will be varies regional to region. Even the type of surgeon that you would be seeing, there's a couple of different specialties that may have an interest in this. And being able to find the right endocrinologist who's really passionate about thyroid cancer and can help guide you in the right direction. But in the general, your need for an oncologist is pretty slim to none. And we usually end up seeing people come with issues if the oncologist is the one leading the charge and an endocrinologist is not the person who's managing things, because this is not behave like 95% of other cancers, and the tricks that we use are different for this particular cancer.
And I'll jump in too, because the radiation oncologist, and I'll kind of include nuclear medicine in with myself, who's radiation oncology. They're subtly different, but we're often the last to meet the patients on the team, actually, because our role is typically after surgery, after kind of the initial upfront treatment, and then after we have the final pathology and can determine the risk of the patient for recurrence. And then we kind of adapt a strategy for after surgery to use different modalities of radiation, which include radioiodine, but also potentially, although rarely, external beam radiation, which is a different type of radiation.
Very cool. So I'm going to start out with some questions for our two doctors / patients here. At this specifically, I'm asking from a patient perspective. What were some things that you were looking for in your medical team specifically, and what did you want out of them? And we'll start with Dr. Oltmann.
So I was like I said, I was in the middle of training. So I at least was in a location that I knew had a very high interest in thyroid cancer. When I felt my nodule, I was trying to figure out if my son and I had cold or allergies at Thanksgiving one year. And instead I felt my thyroid nodule. And so I was able to email my faculty member, who actually now is my senior partner. So she's somebody that I had been able to operate with, and really thought I really enjoyed the meticulousness of these surgeries. And that I knew I was in good hands. And, this is probably, I have a very unique take in that it's somebody I had worked with. I had seen in the operating room what they can do. I've seen their bedside manner to know. So understandably, that's not the typical way to find your surgeon. And then from the endocrinologist standpoint, it was sort of the main endocrinologist that we had at the time that had an interest in thyroid cancer. And so that was my team, because that's who I knew. And I think a lot of it, though, in retrospect, things that I know now that I would look for differently or potentially rate differently if I didn't have the advantage of working with these people is, looking at the support groups to get input from other people. Like, what was your experience with this doctor versus that doctor? And looking at online ratings to an extent.
Ooh, sorry. I delete those, just so you know. I'm so sorry, keep going.
No, but as a patient, to try to get a sense of where you should go, and just your comfort when you meet the person face to face. I think that goes a really long way, because less so with your surgeon, a lot more with your medical endocrinologist. That you're a team, and this is somebody that you have to be really comfortable being a team player, and you need to feel like they're treating you like an equal, because this is not a relationship where everything's dictated to you. And if you feel like they're not letting you ask a question and actually answering the question for you, then that to me would be a really big red flag, because we should all check our egos at the door. And if we feel confident that we're giving you the right advice, then we know that if you need to go for a second opinion, you're going to get that same advice. And that should help you feel just at the beginning, your gut instinct is there for a reason.
Dr. Blomain?
Yeah, that's really great. I'll add some things based on my own experience, but I totally agree with everything you just said pretty much. And in my case, I was 20 years old. I was a junior in college. It was upstate New York in the winter, so like everyone was sick, but I started feeling something's off in my neck. Probably just some eventually what I came to understand, probably just some mass effect or some weird just sensation in my throat from the mass itself. So I go to student health a few times, nothing, it's Ithaca in the winter, everyone's sick. Now it's kind of like a little bit, I think kind of just dismissed or, but then finally someone felt on exam, which I feel blessed that it happened. And then, my spring break was spent kind of getting surgery, but in terms of getting that and that initial looking for my care team and kind of making the decision, I'm going to give a shout out to the caregivers that are in the room and at this conference and maybe watching on Zoom, because again, I was 20 years old. I was technically an adult, but definitely didn't feel like an adult. My family is like a lot of people in medicine, so I felt blessed for that too, because I had a lot of strong advocates on my behalf to bring that expertise to bear. I guess you had it kind of directly in your own self to some extent, but I didn't have that yet, but I had it in the family. And so I kind of trusted my dad, who's a physician, to kind of vet the general volume and kind of medical prowess of the institution and the person. But then once I met the person face to face, I was more kind of focused on how they made me feel. I'm very wired for scan anxiety and lab test anxiety, and obviously being kind of thrown in the deep end with a cancer diagnosis kind of put that on overdrive. So I wanted someone that kind of put me at ease, but also kind of instilled confidence that they knew what they were doing. And now that I'm on the physician side of it, it's it's a challenge. How do I instill that for my patients? Because I remember just how, the right person listening in the right way can kind of really make a difference. And so I try to apply that to my own patient relationships on the other side of it now. And then for the nuclear medicine and the after kind of surgery type treatments that I was referring to, I was wanting to kind of find a thoughtful approach that kind of split the difference between maximizing the oncologic outcomes in terms of lower risk of recurrence and things like that, but also with a mind that hopefully I have many decades left to live. And so managing long-term side effects being kind of front of mind, and maybe trying to find what's that happy medium where you can get the good oncologic outcome, but not necessarily have much in the way of longer term side effects. So we ended up, I know I'm skipping ahead a little bit. We'll talk about second opinions. I did end up getting a second opinion and had two different kind of radioiodine dose recommendations. And we ended up kind of along the concept of what I was just talking about, taking the lower of the two doses. So I kind of looked for that being more of the happy medium of that. But so those are generally speaking what I was looking for. But I think it's like trusting your gut and someone that makes you feel comfortable. That was kind of the big thing for me at the time.
Yeah, so it's a nice unique perspective, right? Because I think you give one of the most poisonous things on earth with radiation, and you have that perspective that, okay, let's first think about side effects. So what I'm going to do is, I know there's some people on Zoom with questions. We'll either save them for the end, or if they're a question that needs to be answered right now, you guys can just interject and let me know. So second opinion, what does it mean, right? So the definition is that get the opinion of a doctor other than the patient's current doctor, okay, or healthcare provider in general is a second opinion. And there are different ways that people see second opinions, and there's a little bit of research out there. But one of the quotes I liked was a doctor from Yale who said, second opinions are good when there's not a perfect answer and you want more input. So it's your comfort, right? I want more information. Whether they're telling me what's right or wrong, it doesn't matter how you know, like Dr. Oltmann was saying, it doesn't matter if the doctor knows that they're right. It's not about them. It's about you, right? As the patient, and they need to check their egos at the door. I like that. So if your gut tells, also another reason is if your gut tells you something is not right, you don't just have to agree to a treatment, especially if it's morbid or you're not comfortable, right? You always have options, you have choices, you have caveats. I realize insurance can be a bummer. Cost to travel places is a huge deal. So it's not always, you know, your choice, but you need to be comfortable. And sometimes even just getting that first, second opinion is good. And then you go back, you know, to something, and you can take, okay, doc, the doc that you're comfortable with, what would you do? What would outline over the next few years look like if all things being equal? And you can take that to your doc, where you can, if somebody has a question, let me know.
Because I think second opinions feeds into one of the questions in the chat really nicely. Somebody was asking about finding out about non-surgical options like observation, active surveillance, or thermal ablation. And I think, you know, when it comes to those treatment options, they do acknowledge the fact that you have to self-advocate if you're looking for that. It is something that's still kind of in its infancy. Active surveillance, I think, is a little bit more further along than thermal ablation. But this is another part where sometimes your physician may ask you to get a second opinion, and that's the physician's way of telling you, like, you don't really want them being in charge. They are not comfortable with this, or they feel like, hey, the more people that are kind of on board, because we may be having to kind of kludge something together, you don't fit into any one perfect mold. The more people that are kind of giving you a reasonable solution might help give some confidence, not just to you as the patient, but also potentially who's taking care of you as your physician, whether it's the radiologist, the endocrinologist, the surgeon. And we have a way to do this informal, or actually formally, as a tumor board, where we'll have meetings to discuss complex patients, where we have all those people in the room. And so in some ways, many of you may have had second opinions without realizing it, that your doctor was actually bringing your case to get the benefit of other people's thoughts and opinions. When it comes to these non-surgical treatments, though, because they are still in its infancy, you don't want to go doctor shopping to get someone to say that they will apply this to you unless it's something that they're really doing a lot of, and so that they can help you navigate those nuances. And so that is where you're going to have to travel to a major city, and there's, you know, select places. RFA is starting to be offered more widely, but most places that are picking that up are only doing it for benign, and they're still very cautious about, even for benign things, who they're offering that for. And so while there are patients where this might be excellent options for, or with recurrences, I know ethanol ablation is another thing that we'll talk about for people who've had too much surgery and have yet another local recurrence. But you really want to make sure, if you're pursuing those options, you're going to someone who does a lot of it. You do not want to be their first case.
Somebody has to be their first case.
Well, and yeah, I think you raised an excellent point about these kind of emerging treatments where it's like they are in their infancy. And this is where advocacy kind of becomes a gray area, because in general, I think advocacy for availability of procedures as a blanket rule is a good thing. But sometimes you have to be a little bit careful when you're advocating for patients to have access to something when we don't know enough about it to say whether it's beneficial. And so, you know, something that might be advertised as like a minimally invasive alternative to conventional treatment, like, really sounds good, but those conventional treatments existed because they were the product of decades of research to kind of establish them as that. And so there's always the risk that the new interventions are not as good. So as we advocate, sure, it's great to have, again, options for select patients, but we have to be careful with kind of shared decision making of what actually goes into making those decisions, and when to offer those procedures outside of, let's say, a clinical trial, where obviously, you know, we all are kind of in support of clinical research to answer these questions, but offering them just kind of as in lieu of standard of care gets very, very murky.
Some of my favorite patients are my ThyCa patients, right? You guys all come well-informed, you have your questions, you come with your books, you know, and I love it. And so if you feel that your docs, you know, there are people who are not comfortable with that, And that's okay for them, but you need to be comfortable, right? You go ask all your questions that you want. So second opinions are good at any time, right? If the patient's uncomfortable, if the doc's uncomfortable, like was mentioned, if the treatment plan is not what you read about or is off. And rare disease, that's everybody with thyroid cancer, right? So that makes it hard. But if you feel that you meet the criteria of the common, thyroid cancer common treatment and you're comfortable with the decision, you can go forward. But if something's off, go get that second opinion. If they agree and you're comfortable with the personality of your doctor, then go forward.
And I'll add one other thing to the second opinion, kind of we'll say almost like non-medical or personal reasons. I had a patient recently who would have commuted probably about 2 hours to get treated. In radiation, sometimes the way we would treat is like every day, every business day for a number of weeks, which is a real like onerous commute over those weeks. And they wanted a second opinion closer to home. And so I think, we do generally, I think, a pretty good job of telling people when, these things can be treated in the community versus when, if it's really complicated, maybe there's a benefit to being treated in an academic center. But I could tell the patient was like, they actually verbalized, I'm sorry for like, I forget the exact word. It was something to the effect of like taking the business away from you. And I'm like, I'm not working on commission. It's not an ego thing. It's not like, I felt like I need to take some extra time, like reassure them, like, this is not that at all. Like, I want you to, I think that the treatment you get in the community would be acceptable. And I think that that time toxicity of that 2 hour a day commute or whatever it may be was for them the best choice. And so that's all at the end of the day, that's all I want, whether it's with me or somebody else. I want the patient to have the best outcome that it encompasses them as a person, including things like that.
We'll see several patients that kind of come back. And so if you're going on a non-surgical or active surveillance, or even patients who are doing a lobectomy, and there's a certain amount of monitoring that kind of goes with it, you want to make sure that who you're going back to is comfortable with that strategy as well. And sometimes, we have several people where I'm in Dallas, we take care of patients all over North Texas and a good bit of Oklahoma and Louisiana and Arkansas. And we will see their local endocrinologist constantly sending back for a random finding. And we're like, no, that's just a normal lymph node. Like, no, we're not taking this out. No, they don't need radioactive iodine. And so what, if there's one good thing potentially to come out of COVID, is perhaps being able to offer more virtual conferences or consults for those indications. So patients who do live more remotely have the option to be able to converse with the experts that may live far away. However, the reliability of your imaging is really critical on being able to make those calls, and the consistency of the same imaging. The machines, everything looks very different from one machine to the next or one tech to the next. And so that can also be, when you're signing up for a particular treatment plan, there's a lot that comes with it down the road that may not be readily apparent right up front. And so trying to make sure as you come up with your team and they're treating you like a team member, is that, okay, well, what is the implications of me making these choices, not for 2 weeks after surgery or a month after radioactive iodine, but what are the implications over the next several years? And how does that fit with where you live, your resources, and your ability to keep that plan?
Yeah, this is very much about you being in the center of all these decisions. There's a couple of terms that have been coined, and I just wanted to point that out. Time toxicity is a cool new one that I have not heard before, but I really like that. And you've heard lately financial toxicity, right? That's how much does it cost you and how much does it cost society? And then the term that Dr. Oltmann was using several times, active surveillance. The gentleman that coined that term is right there in the center, Dr. Mike Tuttle. So attack him afterwards, okay? So active surveillance is when you actively, right? You know that you have something you're actively watching for it to come or that it's present, right? Okay. Or you can actually give a better definition. You just made it up. So in terms of within rare tumors, within thyroid cancer, I would say that, even though all thyroid cancers are rare, if somebody has advanced disease or anaplastic thyroid cancer, or even medullary thyroid cancer is extremely rare, but even subtypes within medullary thyroid cancer are more advanced. And then if you have differentiated thyroid cancer that's radioactive iodine refractory, or have had multiple surgeries, people come and they're like, my tumor keeps coming back, but it may be coming back, but it may also be that they just didn't have that comprehensive surgery to begin with. So all those things are if you're uncomfortable at all. So there's some facts and caveats to second opinion. Remember that you always have the right to a second opinion, and you can always ask your health plan to see how one can do that and how it's allowed. And your health plan has a right to ask you to get a second opinion before agreeing to the treatment that's being offered to you at your place, at your health institution. And then, of course, we talked about financial toxicity. You have to be able to travel there sometimes for it and sometimes just for one time. And the problem is the health plan does not have to agree to that the treatment plan that the second opinion gives you. But, you know, be your own advocate and look into these things, because they will try to like get the cheapest way out. But sometimes if you know your plan, which is very hard. I mean, even just getting healthcare for my own family members, and I'm in healthcare, is very hard. So I'm not trying to downplay that, but if you're at all worried, look into those opportunities. So one thing that we want to get across, I think you've already heard it, is just because you go see someone for a second opinion doesn't mean that the current doctor that you're seeing, you don't trust them and don't like them. So some patients will tell their physician, I'm going to get a second opinion. Nothing against you. But most patients come, when they come to get their second opinion, are telling me, don't talk to my other doctor because I didn't tell them I'm coming to see you, and I'm really scared they're going to fire me, but I really need to see them. And I'm like, your doctor should not be scared that you came to get a second opinion. Everybody should understand that I'm going to see somebody so that I'm comfortable, but I really like you. So I think it's okay to tell that doc. And if you're afraid, that's fine too. Just be open about it. Nobody should be threatened by you wanting another opinion. So a little bit of research. This is just one paper that I decided to share with y'all. Oh, I don't have the reference, I apologize. But a second opinion resulted in changes in the diagnosis about 15% of the time, about a third of the time treatment changed, or in both about 11% of the time. But the clinical impact of that second opinion was estimated as moderate or major, like a big time change rather than a small time change, about 21% of time, and about a third for diagnosis and about a third of the time for treatment. So just, you know, it's not always going to make a difference, but sometimes it does. So if your gut's telling you that and you're uncomfortable, go with it. So questions for our docs here, again, from a patient perspective. I think Dr. Blomain touched upon this, that he did seek a second opinion, but if there are other things that you want to add before we move to the next portion, feel free. And what you looked for.
I didn't seek a second opinion. However, when I had my recurrence, I was further into my training and knew more about thyroid cancer and what was coming down the pike. And Dr. Tuttle, you don't realize this, but when you visited UT Southwestern, one of the case presentations that they presented about 13 years ago was my recurrence, because they wanted to give me more radioactive iodine and I refused.
Did he say the right thing?
He did. He was like, she doesn't need it, because they were arguing with me that I wasn't in the room. They didn't tell me they were doing that, but one of my classmates was like, oh my God, I'm listening to them present you at tumor board right now.
HIPAA violation.
They didn't use my name, but my friend who was the one who had scrubbed in my surgeries was like, oh my gosh, that's Sarah. But in that case, because of my own knowledge in my journey, like when I was diagnosed with my thyroid cancer, I had one child. My kids are 5 years apart, and that is not what I was planning. And right around when I was trying to conceive was when my second child is when I was diagnosed, and I got the first, I was in the old guidelines. So I got a lot of radioactive iodine. I got 165, my first one. And I just remember sitting in the nuclear medicine attending's office when he was going over and just hearing risk of miscarriage, risk of miscarriage, risk of miscarriage. And that's all that stuck with me. And so we waited, and then we started trying to have our second child, and then the miscarriages started happening. And so when they're like, oh, you have a recurrence, you need more, I was like, no, because I looked at my path, my TG, yes, it jumped, but I had a lateral neck dissection. There was only one node that was positive, and it was a very small node. And knowing what I know now, I may not have even signed up for that second surgery. I would have watched it, and I would have been okay with that with what I know now. But I, as a doctor, I didn't even think to ask those questions about the surgery. They're like, yep, you have this. It's biopsy positive. This is what we're going to do about it. I'm like, okay. And so if a doctor gets lulled into the going along with the ride, it's really understandable for everybody else too. Like that's just what happens. You just ride.
I really want to just reiterate and say, thank you to both of you for being so raw and sharing all those things, because I know that that's hard, but I know that lots of patients are facing this, and I think you're helping many people. So thank you both. So turning it around from the physician perspective, Dr. Blomain, I want to start with you. When would you recommend a patient get a second opinion for a radiation oncologist or other members of the medical team? Is there something where you're saying for sure this is a red flag, or is it all just on the patient's gut?
I think so again, I'll try to deal with two separate issues, because there's the radiation oncology, that's the radioiodine, and then there's the external beam radiation, which is a different type of radiation. So primarily radiation oncologists give external beam radiation, which is given with a machine kind of like an X-ray machine, whereas the radioiodine's a pill that goes through your body and is radioactive and treats the cancer that way. In terms of seeking an opinion from a radiation oncologist for the external beam radiation, anytime there's a recurrence, I think it would be worthwhile at least seeing a radiation oncologist. They may or may not offer treatment, but each time we kind of go back into the neck to operate, it gets harder and harder. And so sometimes, especially after the first recurrence, maybe try to prevent the second one, because the main advantage of adding radiation at any point is not so much to extend survival from the disease, although it in some cases does do that in some cancers. In this case, it would be more to just stop the local recurrence in the area that we would treat. In this case would be the neck. In terms of radioiodine, I think you're hearing from both of us that there's some variation in dosing that was present back then when we were diagnosed, but persists to this day, to the point where now there's even omission for low risk patients. And so I think hearing multiple opinions, even almost as a standard of care, is a good thing, because everyone has their own different way of treating, and there's ranges. Someone might be on the fence but offer omission of radioiodine, and then or there might be someone that would offer a dose, but then even within that, there's a range of doses. And I think and then you need someone that really can kind of be thoughtful about it, because I find it's best to kind of lay out a spectrum where some patients want to maximize the effect and minimize the risk that cancer comes back and will pay the cost, so to speak, in extra side effects, where some patients want to minimize the number of treatments they get, and they're somewhat more willing to accept a slightly higher risk of recurrence, and we'll deal with that when it comes. And so kind of laying those out as conceptual frameworks for these kinds of things, I think getting more opinions can actually be helpful. With the caveat that there's such a thing as too many opinions. I saw a patient during my residency training that, not for thyroid cancer, or something else, but I think they had like 15 notes in Care Everywhere, which is the little plug into our electronic medical record that lets us see from other institutions what notes other doctors have put in. So, at that point, what are we really adding? So, but yeah, that's kind of like a funny example. I don't think many people fall into that boat, but yeah, so within reason, I think it's great to do, even when there's a wide range of acceptable practice standards for treating something.
So I just want to add something to, because we all in medicine respectfully agree or disagree sometimes. So just to add something to what Dr. Blomain said, you have to be careful, right? Because when somebody sees a nail, if they have a hammer, they will hit, right? And so sometimes when you go visit, and again, I don't mean any disrespect, when you visit a radiation oncologist, they're like, well, my only tool is radiation, so I'm going to give it to you, right? And it may not be the answer. So you want to talk to your whole team, and hopefully, ideally, your whole team is talking, but you want to talk to your whole team. And then the second thing was about so many opinions. So I just saw somebody who was open, and they were like, you are my fourth opinion, and I'm going to Memorial Sloan Kettering next week. So Mike, they're coming your way. You'll be their fifth opinion. And it's okay, right? I told her, you need to be comfortable wherever you want, She did say she wanted to see me back, though. Let's see what you say. So, Dr. Oltmann, when would you recommend patient get a second opinion for surgery? I'm sure, you see patients that have come to you like, oh, I wish you would come see me sooner, or, what are some red flags that you can tell patients?
So I think that you have a couple of different options. One is just straight out asking the surgeon, how much thyroid surgery do you do? How many thyroid surgeries do you do a year? And in our literature as surgeons, what's considered a high volume thyroid surgeon is somebody who does 30 thyroids a year. That's not even one a week. I'm so far at 200 so far for this calendar year. But still, the vast majority of thyroid surgery across the country is being done by low volume surgeons, surgeons who aren't doing that operation or even in that part of the body that regularly. And so that is a very fair question. And if your surgeon is at all not trying to skirt around the number or being vague, that is a red flag. They should very easily be able to tell you. And if they just say, oh, I do enough, no, they should be able to give you a ballpark number. And that is not you being difficult to ask for that information. Ideally, so with thyroid.org, American Thyroid Association, you can find a surgeon finder. That particular surgeon finder is unbiased to the surgeon's background. They have both endocrine surgeons who are general surgery trained that have taken extra year or two of training specifically in these diseases. And they also have ENT surgeons who may or may not have additional training in these particular diseases. Our Endocrine Surgery Professional Association, endocrinediseases.org, also has a surgeon finder that has, and both organizations are international. And so you can find, for anyone who's listening on Zoom, who's outside of the US, you have an ability to find out who your local resources are. With the ATA website, you also have the benefit, it's not just the surgeons or the medical endocrinologists. You can also find some radiologists, the subspecialists of radiologists who may be options in your area as well. So I think it's, do you feel comfortable? Is the person giving you the time of day and respectfully answering your questions? But it's also, you got to remember which doctor takes care of which thing. You don't come to me to learn about radiation. And you don't go to him to find out what happens in the OR. So you want to make sure that you're going to the right person who's going to give you their expertise, and then from a question standpoint, understand when they are starting to be vague is because you're getting outside of their area of expertise. And if that starts with what you think you're supposed to be seeing them for, then that is a red flag that might not be the right match for you.
Yeah, you can even ask them, what do you think about me getting a second opinion if they look like they're, hedging, or, there might be a reason. You may just have a very rare thing. And I think the guidelines, correct me if I'm wrong, say like if you're a higher volume surgeon, you have to do over 100, right?
So there's, depending on which, so Julianne Sosa's paper was looking at, her first paper was saying 25 and then it was 30. And then the group out of Pittsburgh had another subgroup that was very high volume, which was 50. So, but still
That's per year or
per
total?
year.
Yeah. I was talking about total.
Annual year. So, but I think, 100 guests, that is somebody who's going to be very well versed as to what's happening in the neck. And, it's okay to, if you have a more complex, bulky tumor, if they're talking about, neck dissections, then you can ask not just, hey, how many thyroids do you do, but how many neck dissections do you do? Now, those aren't as common of an operation, so it's might be a little bit of a lower number, but it should still be something that they do, a few times a year at least.
And one other thing, if you're seeing a surgeon and you keep going back to the operating room, you may just want to get another opinion and then come back. It's not that your surgeon's bad, just want to make sure it's not because you didn't have the comprehensive neck dissection that you needed.
Yeah, I think making sure that your surgeon did all of the right tests up front so that you get the right surgery the first time in the operating room. And that really can go for reoperations within the first 1 to potentially 2 years. There's some surgeons, we don't call that necessarily a recurrence in that short time. It's just persistent disease that people didn't look for and are picking up on your surveillance. And having someone who's really well-versed in thyroid cancer, make sure that before you're ever in the operating room, they've kind of done that thorough assessment. It can be a little bit trickier if you're going with an indeterminate thyroid nodule, depending on whether or not you had versus someone who has a known thyroid cancer diagnosis or suspicious for thyroid cancer.
Okay, so in the remaining minutes, we're gonna talk a little bit about oncologist. Can I ask if you guys can look through the Zoom and see if there's anything that we didn't touch or answer? When is it time to see an oncologist? So I'm going to start, and if they have something to add. So I think there's a couple of things very loaded right in your question. What I mean by that is, first of all, I almost always advocate for my patients to have their records. Okay. Don't rely. We have so much trouble getting records from all these places. And when you come as a patient and you're coming to your second opinion and you're wanting them to tell you the answers and they don't even have all the information. And that makes it very hard. So as much, you have a right to your own records, right? The more
my records were too long, they were too much, they refused to send them back important.
That's not legal. So your medical records are yours. They can charge you. If it's thick, they can charge you for, I don't know, different places for number of pages or whatever. But yeah, so it's a little bit easier when you have electronic health record. In general, you should have your notes, but obviously not everybody works like that and not all of them are accessible or forwarded to the patient. So you can go to the, what's it called? The records place, medical records, thank you. And ask for your records, but just be ready. That includes your scans on CDs and, you just can't walk out with your pathology slides, I don't think, right? That is something we have to request. But everything else, the more you know, a lot of our engineers and accountants come with binders, right? I mean, I'm just picking on them because they like track everything. Yeah. And you see some here, right? But the more you have, then even if someone has trouble getting your records, you can bring them or scan them into a new patient office. Now, the second part of that, which is your main question, is do I say that I'm coming for a second opinion? And the second opinion can have very different implications from an insurance aspect and from a legal perspective. So you don't have to, I think you should be open with the doctor, or the healthcare providers that you're seeing. But I don't know, we can ask others what they feel. I don't know that you need to say it to the upfront person unless you're saying, I don't want to pay. So for example, if you come to see me, you're going to see my surgeon typically if you have recurrent disease as well. And you're like, I can only afford one person, or I can't afford the scans, or my insurance won't pay, so I just want to pay for that opinion. Then they'll read you the spiel like, okay, Naifa can't do her job without, her team, blah, blah, blah. But if you're willing to do that, you can do that. So I think if you use those words, and I don't know how you guys feel, but if you use those words, it has very different implications, but you can be open with the team. But I would get the records and you can say, I have recurrent disease, or I want to see, and you can say, I want to get another opinion, but I'm thinking about the legal.
If you do that,
ahead of
it's
time.
really helpful for us to get it like a week or two ahead of time, because that way, before we're actually in the room with you, we can comb through all of it. And so for many of us, this is like a decades long thing, and sort of trying to get the timeline down and tracking what happened when and which radioactive iodine dose and how much, and being able to add it up and seeing your thyroglobulin trends and was it stimulated or suppressed, and all of that. And then the path records as it kind of gets scattered. And if people have had more operations, it does take time to be able to put that all together. And so that way, when we're actually in the room with you, we can have, and we're not spending time, your critical time and our critical time together, trying to put together that timeline. And so ideally, if we can have it at least a full week with a full weekend to be able to kind of comb through and get through that. But whether you're a new patient or a second opinion, we need all the same information.
Believe it or not, when you walk in there, you want them as prepared as possible. They're not just like, oh, let me hear your story and make up they want, because you're coming with a complicated story most of the time. Oh,
there's a lot. And then it's because while the hospital system might be EMR, individual practices may not. And then if you're getting your images at imaging centers, the report might load in, but the images then don't. And then there's a couple of different major companies that are EMRs, and they do not talk together either. And it doesn't help for anything that's behind when the EMR started. And so, most of the EMR integration has really been more heavily in the last 10 to 15 years. Many people in the room, their cancer journey started long before that.
So even if they both have Epic as one example, I know she wasn't using terms on purpose, doesn't mean Epic talks to Epic. There is something called Care Everywhere that you heard about, but they have to get permission from the patient and it has to be released. And then we have to get that specific thing, and we still can't look at the pictures. So I know it sounds archaic, and the people who do digital stuff, IT stuff, and the CFOs, and they come into your office and they're like, I don't understand this. I could consult for you. This is terrible. What is this? Right? It's backwards. So any legislation, any help in the companies, guys, come on down. Sorry. We have 3 minutes, so we're not going to cover the oncologist. If somebody wants, they can come and talk to me. It's not.
I'd just like to take, there's a couple questions in the chat about radioiodine, so I'll take those. There's an anonymous person, I'll just read the comment. Any confidence instilling words from Dr. Blomain for people who are terrified knowing that they will have RAI soon? Radiation being the most poisonous thing you can give a person makes it seem extremely terrifying. Yeah, I completely understand that perspective. I was right there with you. I was very, very nervous getting my treatment. I felt nauseous from the nerves. And then you can imagine that there was a rush to give me a nausea pill because if you vomit radioactive material, it's not a good situation. So I'm confident yours will go more smoothly than mine did in that way. At least I hope it will. But yeah, I think there are side effects with radioiodine. Radiation, if misapplied or applied kind of in more kind of intense situations where we need to kind of get tumor control, can actually have side effects. Radioiodine does have side effects, but I would say it's not on the high end of the toxicity spectrum for treatments that involve radiation. Tomorrow, I'm actually giving a talk on some of the side effects from radioiodine. So I'd encourage anyone interested to come and hear more about that if that's not too self-serving to plug that, but I'm excited to talk about it. But yeah, I think, I think it's all a risk benefit. Unfortunately, when we get these diagnoses and have this journey, we don't kind of want to be here, but I think the benefits of treatment generally outweigh the risks when you're being recommended by providers you trust and physicians you trust. And I think that's why it's important. All these other issues we talked about, second opinion and trusting the opinions of the people around you. I would take confidence in the fact that those people you trust have kind of calculated that risk benefit in the favor of giving it, and just try to take it one step at a time. And I think you'll be fine.
I guess there was one question about just practice patterns by physicians. Everyone has different work habits. And if you think to your particular work environment, there are people who always are 5 days ahead prepared. And there are others that are squealing in 5 minutes late with papers fluttering out of the back of their car. And the medical profession is no different. And we all have different practice patterns as to how prepared we are before we walk into the room to talk with you. And sometimes we might have a particular standard. However, something may have happened before they walked into the room with you that day. There may have been an emergency elsewhere in the room, or there may have been a consultation that went extensively longer that ate into the time where they would have normally been reviewing your records. And so while, yes, in general, the perfect world, your physician will have kind of looked over some of this stuff before they have the opportunity to sit down and chat with you. If you're coming straight from the radiologist to that appointment, though, they probably haven't, because the report's not there yet. So sometimes, in my practice, they're coming straight from radiology to my office. And so I'm pulling up the pictures and looking at the pictures with them because the report's not there yet. So just realizing we are talking about sort of on our perfect day and sort of the best taste, but we're all human. And so just trying to make sure we're not also making you think that you're not getting the right treatment just because, these ideal expectations of like super prepared and reading through everything in advance. Yes, we would always love to be able to do that. Sometimes we can't. And so that doesn't mean that you're getting bad care or that you have a physician who's not interested in you.
So really, in the last 5 seconds or so, I just want to say that so there is an initiative for patient education handouts. This one is specifically for medullary thyroid cancer, but they're looking for feedback from patients. So if you can scan the barcode and just put in your feedback. So thank you so much for all of your attention. It's been great.